Everyone's here.
Everyone is already here, Doctor.
Okay. Okay. Okay, let's start with semua kitab Al-Fatihah. Okay, thank you very much for attending the. This is going to be last session and last session for before the exam next week. Yeah, exam next week. Yes, exam next week. After Raya, so you got time to celebrate lah kot. Ke korang tak dia nak balik ke kampung? Tak eh? Boleh balik kampung. Oh, kesian. Sorry lah. Okay, fine. So all of you are in campus?
Yes.
Including Idlan as well. Idlan,
Yes.
background dia different. Looks like he's at home. Okay. Well, anyway, this is one of the we hope that your sacrifice and not celebrating Eid with your families will be counted as a good deeds, for the ummah lah, for the sake of the nation and for the sake of your family and also yourself as well, and obviously you praying that all what you do for the past 5 years will be counted as a good deeds. And will be counted maknanya dia memberikan timbangan yang berat on the yang belah kanan instead of on the left side. Okay, so I don't know what is the session today is about. It's about procedure, and I'm sorry that my mind is not really with you guys. I've been very busy for the past few weeks. So it's a procedure punya presentation. So have you guys prepared any procedures or ataupun? Okay, good. So I'll leave the. So who's going to present? So
We will present first.
Okay, fine.
Okay.
All right. So I'll leave to whoever is presenting your topics. Okay.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So as for today, I will present for peripheral inserted central catheter, or we known as PICC. So this is my outline of presentation. First of all, we need to know what is PICC, and then the indication and contraindication, advantages and disadvantages, the type of PICC itself and its components, the procedure, the complication of PICC, and also last but not least, PICC care. So what is meant by PICC? It is a catheter inserted usually from the peripheral veins to the to reside to the superior vena cava. PICC can last for average of 6 months and can be up to 12 months or 1 year. So usually site of insertion is more on arm vein, which is basilic, cephalic, and branchial vein, and less common in common femoral vein except in neonates. Okay. However, for late common femoral vein, it's usually reside in at tips at the inferior vena cava. Right. So what is the indication for PICC? First of all, it would be long or intermediate therapy, such as infusion of drug or any administration of chemotherapy. Any continuous inflammation, we also can administer through PICC. If the patient have full venous access, for example, peripheral vein, administration of drugs or fluid that may be irritable to prevalent, for example, such as noradrenaline or any vasoactive drug. And then frequent blood draws, and also TPN also we need to deliver can be central catheter or can be PICC as well. PICC is also a style of central catheter. All right, so relative contraindication, if the patient have none of thrombosis, have positive blood culture, it means whether the patient in infectious or shocks, skin infection at the insertion site, future dialysis patient, and also if the patient have fistula or AV graft in the same extremity, for PICC we plan. So might consider PICC on the contralateral arm. So for the advantages of PICC, so it's eliminate multiple venipuncture, for example in blood taking samples, offer increased hemodilution, is usually cost effective and time efficient. It's also decreased risk of infiltration or extravasations. It's easy. It may be inserted at the bedside. It's increased patient satisfaction because if you use central catheter, it's at around the neck, so it will be less comfortable for the patient. It also decreased and eliminate risk associated with insertion into the chest or neck of for PICC. But the disadvantage is require adequate peripheral veins. However, if the peripheral vein is collapsed or in short, it might be difficult for PICC. And also smaller gauge size when comparing PICC to other CVC. And the PICC requires special training and from the clinician is involve ultrasound or fluoroscopic guided to put PICC. And it requires practice and continued education to maintain competency. And in PICC, usually need more care rather than other catheter. So type of PICC and its component, we can, as you see in picture, you can see that there are three types right here. It can be single lumen, double lumen, or triple lumen. And for the components, you can see this is the line or lumen for you to insert the IV infusions. And then there is clamp, and then this is the securement device, and then IV connector and grease inspecting cap. Okay. So for the size of catheter, we call it as French. So French is the catheter size itself lah. So seat French same as 2 millimeter. We measure of outer diameter of the catheter. So sizing of PICC is depend on the patient age, patient weight, and also the site of the vein itself. For example, in 1.9 French is usually used in neonates, while seat French 2 millimeter is used for adults. Or this and the more is correlate with the age and age. Right. So before we doing procedure, we need to ask consent from patient or guardians. We must examine the patient to identify the suitable veins for PICC and then measure the maximum insertion distance. So how to measure the maximum insertion distance is we take off the insertion site, which is whether brachial vein or cephalic vein or basilar vein, and then measure to the axilla, and then from the axilla to the sternal notch, and then usually until the sternal notch, but we can go up further to the first rib, between the first and second rib. It's also applicable for the left arm. So the left arm will have more longer lah than the right side. All right, so let's watch video how doctor put the PICC. So this is the material needed for the procedure of PICC. So that's how the procedure is being done to insert the PICC. Okay, this is the further explanation about the procedure lah. It's using the modified Scandinger technique. Okay. So after doctor insert the PICC, so we must check the line whether it's the tip is well positioned through the X-ray. So for neonates, usually the tip should be within the cerebral cover but above T4. And for lower limb, it must below T9. Okay, so these are the X-ray example of the PICC tip. Is above T4 or below T9. For adult, it seems is more on the side at the tip of superior vena cava. So here, this example of malposition of the catheter. For the left side, this go to the internal jugular veins. This go to the azygos vein. It means it's go below the superior vena cava, and then this into the axillary vein. So you must check after PICC have been put. Okay, so the complication of PICC, the more diameter of the PICC, the more lumen, so there will be more risk of thrombus formations and have phlebitis or inflammation of the vein, catheter malposition as the X-ray show, and also can be catheter damage. So PICC care, usually after we put, so we must flush each line every 24 hours, changing the IV connector every weeks, and also changing dressings for every weeks. And if we suspect we can put antibiotic prophylaxis if needed. Think this is my reference. You can refer this later. So that's all for me. Thank you. So any questions from the floor?
Okay, guys. So PICC is a very good thing, especially for neonates, because if you got a very preterm babies, like if you got a 26-week ataupun 28-week baby, you know that this baby will need TPN because you normally tend not to start feeding immediately. You probably need to wait for 1 or 2 weeks before starting them to feed, because the sooner you feed them, because preterm baby tend to develop necrotizing enterocolitis, so that's why you want to go for slow feeding. Maknanya you build up feed very slowly. That's one thing. So because you feed them slowly, so they don't really get good calories intake. Maknanya adequate intake probably not enough. So that's why you start them on TPN. So most of the new preterm babies or extreme preterm baby will need TPN regardless of their condition. That's one. The second thing is, if you got a baby yang ada NEC that need to have a surgical removal of the bowels, then they will need TPN as well, because once you do the laparotomy to remove their guts and their bowels, so they need to be on the what I call it. They need to have gut rest. So they need to rest their guts from the feeding. So how they're going to get the calories is by giving them TPN as well. So those are the things about TPN. If you got a patient with leukemia yang has been on chemotherapy, then they develop, we call it mucositis. Mucositis means that you got inflammation of your oral fecal roots, and then from the oral to the fecal peeing roots, they got mucositis or inflammation of the mucosa that lining up your gut system, your GI system. So because of that, because of the chemotherapy that lead to mucositis, the problem with patient yang oncology, hematology pain condition, you cannot stop their chemotherapy because it is their treatment. So at some point, because of the mucositis, you need to give them gut rest as well. You need to rest their gut. So you give them TPN as well. And most of the patient yang ada chemotherapy ni, they already had their Broviat line ke central line already, so no problem lah. Tapi for those yang tak ada lagi, then what you can do is you can put the PICC line as well for TPNs. So there's so many indications for TPN anyway. So the one that Idil mentioned just now was Saldinger method. And Saldinger method is basically the idea of Saldinger method is they have, we call it guided wire insertion. So meaning that initially, if you look at the video, they have a very small needles going in first. So they put the needles in first and they puncture the veins. But the needles is quite short, so the needles won't go into the SVC anyway. So once you puncture the veins, you maintain the access to the veins, and then what they did after that, they put in the guided wires. Put the wire inside the needles, and then the wire will end up in the big veins. But at the same time, the wire is still connected to your arm anyway. So you hold the wire at the site of injection, and so inside of the insertion, but at the same time, because you already measured the length, so normally the guided wire is quite long, probably about 30 centimeter, or depending on the size of your PICC line. So you expect the tip of the guided wire will be at the aim position, and then after that you get your PICC line, then you just insert through your PICC line. Mana guided wire itu masuk dalam dia punya lumen of the PICC line. So once the PICC line will follow the guided wire and end up in the vessels. Then once you think that the tip of the PICC line already near the vessel, near the aim position, then you take out the guided wire. You basically, after that, you just secure the PICC line, and then you go for X-ray to check the position. Okay, just the thing you want to make sure the tip is not on the wrong place. Macam Ilan cakap tadi, not going to your neck, not going to the axillary vessels, and not not going to the tempat-tempat yang not supposed to be. Because if the tip end up in the small vessels, then it's going to get damage, thrombosis, thrombophlebitis. If it go up to your neck, sometimes it can cause hemorrhage, ataupun it can cause thrombosis or emboli as well. So you need to be very careful when you check the line. And then normally what we do is, while you're waiting for the line to be checked by X-rays, you run clear fluid, for example, probably normal saline or dextrose until you got the X-rays to check the line. Because you still want the line to be run with clear fluids, because you don't want the line to be clotted or to be blocked by the blood clots. So those are the way of doing a PICC line. PICC line in units is very easy, because you just look at the superficial vessels, normally on your helicobacter fossa, or using the great saphenous vein, yang big saphenous vein, then you just use that. So you don't need to use the ultrasound machine. Even in children, small children, that you can see the vessels very well, the veins very well, then you just macam buat macam biasa lah. Cuma you got other equipment to put through into the granula. So those are the ways. So normally if you got big children yang dia punya vessels tak nampak sangat, then you can use the ultrasound scan. Or you got a 7 months ke 11 months yang quite chubby, quite chubby, yang difficult to see the line, then you can use the ultrasound machine as a guided for you to puncture the veins. So, but the idea is there lah. So the Saldinger method, Saldinger ke Salpinger? Salpinger kan?
Saldinger, D.
Saldinger, I can't remember the name. So those are the technique that they use. So you can Google, you can see in the YouTube as well that method, and obviously you will see this method a lot of time once you doing neonatal attachment ataupun neonatal punya retention in your housemanship. You probably will do once or twice depending on how your MOs let you doing it. But I'm sure that big hospital, big neuro clinic, we will get the chances to do it yourself. Okay, any question about this procedure? Okay. If there's no question, then we move to the other procedure.
Tak slide. Nampak kan?
Okay.
Nampak. Okay, so Assalamualaikum warahmatullahi wabarakatuh. So my name is Rahil and I will present about chest physiotherapy and also suction. So for chest physiotherapy, it is an aspect of bronchial hygiene which aims to mobilize the pulmonary secretion, and it consists of a group of techniques which includes chest percussion, vibration, and also postural drainage. And then after this techniques is done, it is followed by directed cuffing or suctioning of the patient who has difficulty or inability to cough out the secretions. Then objective of chest physiotherapy is to move the bronchial secretion to the central airways via gravity. And then if we use external manipulation of the chest, it is to eliminate the secretion, same by cough or aspiration with a catheter. As if when we do chest physiotherapy, it may improve the mobilization of the bronchial secretion, which improve the ventilation of the patient. Okay, so who needs chest physiotherapy? The indications is to patients whom cough is insufficient to clear thick, tenacious or localized secretion. For example, in patient with cystic fibrosis, with bronchiectasis, atelectasis, pneumonia or lung abscess, which contain thick mucus secretion, right? And then for contraindication of chest physiotherapy is in patient with increased ICP, patient who has unstable head or neck injury, who has active hemorrhage or hemoptysis, and also recent spinal injury. It is also contraindicated in patient with rib fracture, who has flared chest, chronic hypertension, and other blood disorders such as anticoagulation. And also patient who has undergone thoracic surgeries. Okay, and then the assessment needed before we perform chest physiotherapy. Firstly, we need to assess the vital signs of the patient, and then we need to know the patient's medication. If patient have taken any blood anticoagulant or any hypertensive medications. And then we also need to assess any contraindications that has been stated before. And then we must perform a detailed chest examination to determine the exact segment or area of the mucus in the lungs. And then we review the patient's X-ray and also do other blood investigations. Okay, there are 3 techniques in chest physiotherapy. The first one is percussion, or it is also known as clapping or cupping. The second one is vibration, and the third one is postural drainage. For percussion, it is a technique that involves rhythmic tapping on the chest wall or over the area that drains to force secretion into the larger areas for expectoration. Basically, it depends on the area. The therapist can use single or both hands. So how do we do it? Is that firstly we need to position the chart so that the part of the lung that needs to be drained must be higher than the other part of the lung. But we need to make sure that the patient is comfortable and also relaxed in the position. So, and then we need to make sure our hands, the therapist's hand is in cup-shaped hand like this. The thumb touch and also the hands are cupped like this. Or we can also use a mechanical percussor such as percussor cups. And then after that, after we position the patient and also make sure our hands is in the right position, we perform percussion by vigorously striking the chest wall alternately with our cup hands. And if it is done properly, it won't be painful, and it should not be painful actually. Okay, and then when percussion is performed, a hollow sound should be produced, and then we must perform over a single layer of clothing. We must not perform over the bare skin or not over buttons or zippers. And then we can perform it for about 1 minute, several times a day, and it actually depends on the thickness of the secretion of the patients. And then we must perform before meals or at least 30 minutes after meals, because it may induce vomiting to the patient. In younger children, we can perform percussion before nap time or bedtime, because it can put them to sleep. Okay, so let us watch video.
This is a demonstration of the
By the way, can you hear the video? Is there any sound?
percussion technique that is only to be done
Is there any sound? Okay.
on the advice of a physiotherapist following assessment. My patient is currently in side lying. In this position, you can use the ribs to mark the bottom of the lungs. From here, you know where to start your treatment. Place a folded towel over the area you wish to treat. With a cupped hand and soft wrist, you can start your percussion, either on the side or the back. Whilst you're doing this, you need to ensure that your patient is comfortable throughout and they are not breathless. Percussion should be done between 150 to 200 claps per minute. That's roughly 2 to 3 per second. Once you feel you've done enough at the bottom of the lung, you can then move to the middle of the lung. Move your towel accordingly. At this point, your patient may feel the need to cough and clear, in which case sit them up and allow them to do so. Move on to the middle of the lung, again, either on the side or the back, ensuring the patient is still comfortable throughout. If the patient again feels they need to clear, then allow them to clear. Otherwise, if you feel you've done enough in this area, you can then move to the top of the lung. If at any point during this the patient feels uncomfortable, please ensure that you move away from this area. Once you've completed one side and the patient hasn't managed to cough and clear, turn the patient to make sure you do the other side as well. Not only can you do it in side lying, you can do it in sitting. Place the towel across the patient and continue your percussion. You can either do it behind, working from the base up, or you can do it across the front of the chest.
Okay. So actually from percussion, we need to make sure that our hands is properly in the correct position, which is cupped, to make sure that the cushion of air is trapped, so that it will soften the secretion, so that it will be an effective dislodgement to the larger airways. Okay. Then next technique is vibration, which is it is a gentle shaking pressure that is applied to the chest wall to move the secretion to larger airways. In vibration, we use rhythmic contractions and also relaxations of the arm and shoulder muscles over the patient chest. So we can also use one hand or both hands overlapping each other. Okay. So when doing vibration, we need to, this is the correct hand position for vibration. It is not cupped, it is flat. And then you need to place the flat hand firmly against the chest wall at the desired area of the chest. And then we need to ask patient to inhale and exhale before doing it. And then when patient exhale, we vibrate the chest wall as the patient exhales slowly. And then after the vibration, we should encourage patient to cough and expectorate the secretions. Okay. So, okay, so this is another type of vibration. This is one hand. Sorry. Okay. So as percussion and vibration is actually a very technical procedure. So it is usually effective when it is done by a very trained physiotherapist. And then the third technique is postural drainage. It is a technique in which different positions are assumed to facilitate the drainage of secretion from the bronchial airways. Okay, so in postural drainage, a patient can be given bronchodilator or nebulization before the drainage to relax the muscle airways and later loosen the secretions. Then we can do it 2 to 3 times daily, depends on the degree of the congestion. And then we need same as percussion and also vibration, we need to avoid performing after meals, as it may induce vomiting. So how it is done is that the patient will be positioned tilted or at a prop up position, but it must be performed based on the clinical findings, as the patient does not need the drainage of all the lung segments, right? So if this secretion the apical segment, it is there are specific position for the patient. So the lower lobes require most frequent drainage, as the upper lobe can be drained by gravity. So these are the positions. So in this positions we can do it for the young children or infants. This is for older children. For example, the secretion are at the anterior upper segments or the upper lobe. So patient will be sit in the prop up position with bent knees, so that they will be relaxed during the drainage. Okay, and then after we position the patient have to remain in that position for about 10 to 15 minutes if the patient can tolerate it. And then after 15 minutes, we can perform percussion or vibration while patient remaining in that position. So the sequence is that firstly we position the patient, and then we do percussion followed by vibration, and then we encourage coughing and or suction. Okay, next is suction. For suction, it is basically an aspiration of the secretion through a catheter, which is connected to a suction machine or wall suction outlet. Okay, and then sites of suction can be done on nasopharyngeal, oropharyngeal, endotracheal, also through tracheostomy. For nasopharyngeal and oropharyngeal, it is usually to clear the upper airways from the oral and nasal cavity or pharynx. And then for the endotracheal and tracheostomy, it is to clear the secretion from the tracheobronchial tree. And then the aim for suction is to remove the secretion and then facilitate ventilation of the patient. And then it's also to prevent the infection from the lodgement of the secretion and to obtain sample secretion for diagnostic purposes. Then what are the equipments needed for suction? Firstly, we need to make sure there is an oxygen source, such as we maybe we need a venturi mask or nasal prong for the children, and then we need to have monitoring equipment such as oxygen saturation, heart rate, and blood pressure. And then we need to have the suction apparatus like this one, and suction catheters with appropriate size to the patient. And then we need to have sterile gloves, apron, mask, and also alcohol hand rub, and also sterile water for irrigation. And then this is the suction catheter size. Usually for infants, we use 5 to 8 French size, where the older children we use 8 to 10 French. I'm not mistaken. Okay, but it depends on the thickness of the mucus as well. Okay, so indication for suction, it is basically for patient who are unable to cough up and expectorate the secretion. So if the patient have like on active cough, has large secretion volume, thick secretion, or if the patient is very fatigued, have poor muscle tone or low level of consciousness, then when can we get a clue that the patient need to have suction? If that if we can see that this respiratory distress, such as abnormal respiratory rate, abnormal breath sounds, as there is nasal secretions, and then gurgling or drooling, or patient is restless. And then the contraindication or precautions of suction. Firstly, the contraindicated patient are patient with pharyngeal obstruction, patient who has acute pulmonary edema, or patient with risk of skull fractures. Because the possible complications is that the suction catheter may goes into the intracranial space. So if to avoid this, we need to use only the nasopharyngeal airway suction, the oropharyngeal airway suction, not the nasopharyngeal airway suction. Okay, so the precaution need to be taken is a patient with a bleeding risk, hemodynamically unstable, hemoptysis, acute face, neck, or head injury, septal deviation, or prior nasal injury, or patient who have recent oral injury or surgery. Okay, so these are the possible complications of suction, which it can cause trauma, bleeding, vomiting, bradycardia, spasm, airway obstruction, or intracranial placement of the catheter. It may also cause the migration of the airway, epistaxis. It may also stimulate the gag reflex, biting reflex, and can also cause dental trauma to the patient. Okay. So before we perform the procedure, we need to do comprehensive respiratory assessment to make sure that there is an effective suction will be done. And then we need to explain procedure to the patient and parents to reduce the anxiety of the patient and so on. And then we need to prepare the patient physically, psychologically, and also pharmacologically. For example, if we need to sedate the patient, on. And then we also need to ensure the equipments are all available, and we need to also ensure that the correct suction pressure is set. Usually in children, we must avoid going over 100 millimeter mercury. But in older children, we can use more than that. Okay, and then we have to calculate the appropriate size of the suction catheter. Okay, and then wear mask, apron, wash hands, wear gloves, and then provide semi-formless position to the patient. This is prop up position, and then place towel across the patient's chest. So this is the semi-formless position. But if the patient have atonic or cannot move, has a neuromuscular disorder, any position is possible for suction. So, okay, for when performing the procedure, we need to turn on the machine and then remove the oxygen device, such as mask or nasal prong. And then we need to estimate the length of the catheter to be inserted, and then insert the catheter into mouth or nasal cavity. Later, we can watch the video as well. Then move the catheter into the cavity until the suctions are cleared, and then replace the mask and rinse the catheter. So let's watch the video.
In this video, we shall learn about oropharyngeal suction. Suctioning is used to remove secretions from the mouth, from the oropharynx, and from the nasopharynx. It is indicated in any infant who is unable to clear the secretions on his own. Look at this baby. He is a term baby but has poor muscle tone and is floppy. This baby might not be able to clear the secretion from his mouth. Hence, suctioning is indicated in this baby. For suctioning, we require suction catheter which has a thumb control. We use 5 to 6 French for a baby who is preterm and 8 French for a term baby. We require sterile gloves, distilled water or normal saline, and a suction machine. We shall now see the procedure of oropharyngeal suction. Wash the hands thoroughly and wear gloves. Now, attach appropriate size suction catheter with the suction tube. Occlude the suction port with your thumb and set the negative pressure at 100 mm of mercury. Before suctioning, estimate the length of the catheter to be inserted by measuring the distance between the tip of the nose and the tip of the earlobe. Make sure that the catheter does not touch the skin during the measurement. Insert the catheter gently into the mouth until the measured distance is reached. Remember, the negative pressure should not be applied while inserting the catheter. Apply suction by taking out the catheter. Slowly rotate the catheter to ensure proper removal of the secretion. Limit the attempt to about 3 to 5 seconds. After suctioning the secretions from the mouth, do nasal suction. For this, insert the catheter gently upwards and backwards into the nares and apply suction. Then repeat on the other side. After suctioning, rinse the catheter and then discard it as per the universal guidelines. Always reposition the infant after you have performed oropharyngeal suction. Remember, avoid suctioning for 30 minutes to 1 hour after a feeding session, unless and until it is absolutely necessary to establish a patent airway. Suction only when it is required. If suctioning increases the risk of vagal response, which can lead to bradycardia and apnea. never exceed a suction pressure of 100 millimeter of mercury. Oxygen source and a bagging mask should be available at the bedside during suctioning. Thank you.
So after the suction, like the video said, we need first to reposition the patient, and then we have to evaluate the respiratory status of the patient, and then remove towels, gloves, and then wash and clean all the equipments used, and wash our hands properly, and then document the procedure and also find. That's all for me.
Okay. So yeah, suction and chest fissure normally been done by the physiotherapist, and also sometimes can be done by the nurses. The most important thing about suction is you don't really go further down than what you can see. So normally, if you can see the oropharynx, you just suck on from the oropharynx. You don't really go lower than that because you don't really want to induce vasovagal stimulation, because sometimes it can cause bradycardia as well. My experience with suction, there's one patient that been discharged home with home suction, but the patient has left hypoplastic heart syndrome at that time. So mom been doing suction regularly, and mom been trained how to do it anyway. But at one point, when mom overdoing things, so sometimes it can induce vasovagal stimulation, cause bradycardia, and that patient basically died because of the overstimulation of vagus nerve that lead to the bradycardia. Plus, on top of that, the patient already had cardiac condition anyway. So sometimes you need to be very careful when you train parents about suction. Do not really overdoing it, and sometimes do not go further down than what you can see. So obviously kalau macam physiotherapy tu dia been trained as well to do slightly lower suctioning, so probably into the upper part of the respiratory tract lah, tapi tak adalah sampai going down to the vocal cord, the trachea and so on. It just still quite superficial suction anyway. Suction is very good. Chest fissure and suction is very good in terms of obtaining sputum samples for culturing, sending for viruses detection as a tool for diagnosis, which is a good thing, especially kalau ada recurrent chest infection. You really want to know what kind of bacteria down in the throat, because it could be MRSA, it could be multi-drug resistance bacteria due to immune deficient punya patient and so on. So it's very good to obtain a sputum sample via the chest physiotherapy and also suction as well. Okay. So that baby yang dalam video tu, what do you think the problem with the baby? Is it just preterm baby? Is it just babies? Or is it just congenital pneumonia? What was the problem with the baby? Looking at the baby's punya well-being just now. Go ahead. You put the tubes up. You should know what's wrong with the baby kan. Mesti ada description. Dalam tu mesti ada description baby dalam YouTube tak ada?
Tak ada.
Mesti ada kan. Baby might have. The presenter comment about the babies and something about the baby that they comment. So you should kind of knowing what was the problem with the baby lah. Apa? Apa cakap dia?
Baby was atonic, like
Astonic.
atonic.
Atonia. No, that baby was moving kan. You can see that there's arm movement. Atonia basically not moving at all. Atonia basically there's no tone. That's atonia. But what was the baby's position when you see the baby just now?
Preterm
Huh?
rest.
Macam preterm resting. Resting position. Aziz, what was the baby doing just now? What kind of posture is that? So normal baby should have flex posture, and upper limb and lower limb should have flex posture. So that baby kind of
Lower limb extension. Macam ada.
extension. Kalau extension macam ni extension? Extension macam ni. Extension. Kan?
Tadi, okay.
Betul tak? That's how you extend. This is extension. It's a hypotonic posture kan? Betul tak? Hypotonic posture. Yeah, so there's some movement, but you expect baby should be in normal position of the baby, especially for newborn, should be flat posturing. And the presenter actually mentioned about hypotonia baby just now, one requiring suction, regular suction. And so that baby might have spinal muscular atrophy ke, ataupun congenital myopathy ke. So it's all about neuromuscular disorders lah. So that, because of the neuromuscular disorder, you got a very weak respiratory chest wall muscles. Sometimes they can't really cough properly, and sometimes they might have breathing problem as well. And so that kind of baby will need regular suction. Otherwise, they might have aspiration pneumonia from their own saliva, their own sputum, and so on. Okay, so that's second presentation. Ada lagi ke kau nak buat dua lagi ni?
Ada lagi 3 tu.
Oh, ada 3? Wow. 5 semua. Okay, yang ni memang pukul rata semua ni. Okay, carry on. Siapa lagi macam ni? Oh, Rahim present 2 topik. Apa yang present ni? Okay, fine. Alright, go ahead. Alright, EEG, great. You should put application and also interpretation of EEG electrodes. That will be much better topics to talk about. Okay, all right. The floor is yours.
Okay, so for application of EEG. First, what is EEG? EEG is a test to measure the electrical activity of the brain using the electrodes which we place on the scalp, and the depiction of the electrical activity occurring at the surface of the brain, most specifically on the cortex. So the electrical activity will appear on the screen of the EEG machine by wave of varying frequency and amplitude, in which we measure using voltage. Yes, so okay. So for indication of EEG, it can be most commonly to diagnose epilepsy, and also if the patient have seizure, we want to know the type of seizure, and also the location of the seizure itself. It could be on the temporal ke, okay, temporal ke frontal ke, and then evaluation of the altered mental status, meaning if the patient have a altered mental status, we want to know if it is caused by encephalopathy or due to strokes. And then also a common indication will be a sleep disorder. Usually we want to, EEG is done to look for the different sleep stages that the patient have. And then best test confirmation, meaning if the ECG is silenced, basically we can confirm that the patient have brain death. But if there is any brainwave activity, then we cannot say that the patient is brain death. And then preoperative evaluation for epilepsy surgery. So meaning we want to know the localization of the epilepsy, and then we can just specifically attack that part of the brain that causes epilepsy. So the most important thing to know about EEG is International 1020 system. So I found a video that maybe will help you guys to understand more.
Start with the terminology. The system by which EEG electrodes are applied to the head and then displayed on EEG recordings is called the International 1020 system. The International 1020 system is a standard method of measuring the head and placing electrodes. It depends on 4 main positions on the head that are easily transferable between patients. First is the nasion at the bridge of the nose, then the inion, the bony prominence at the back of the head, and then 2 preauricular points just anterior to each ear. Consider this diagram of a head looking from the top down. The first measurement that is made is from the nasion to the inion, front to back. This measurement is then divided into 10 and 20% increments, and this is how the 1020 system gets its name. Marks are placed, and then a measurement is made from one preauricular point to the other. Again, this is divided into 10 and 20% increments, and additional marks are made. Further marks are made around the circumference of the head, and separated by 10% increments. And then parasagittal measurements are made, separated by 25% increments. And finally, transverse measurements are made. The intersections of these 2 lines is where the final electrodes are placed. Once all of these marks have been placed, the electrodes can be applied to the scalp of the patient. The electrodes are labeled as is shown here. The system is very simple, and each electrode is represented by letters and a number. The numbers indicate the side of the head, so that odd numbers are on the left side and even numbers are on the right. In general, lower numbers mean that the electrode is closer to the midline, so you can see here that C4 is closer to the midline than T8. And the midline itself is represented by a Z, which stands for 0. The letters are indicators of the position on the head. In this central chain of electrodes, you can see that the F stands for frontal, the C for central, and the P for parietal.
So basically to summarize the video, the international 1020 system, what we want to know is the nation part, which is on the top of the nose, the inion, which is on the back of the head, and then right and left preauricular, which is the anterior to your ears. And then once you have these points, you can put the necessary electrodes, in which we indicate them according to the letters, which is FT for frontoparietal, and then frontal for F, central and occipital and temporal. And then like the video said, from the left side we use odd numbers, while on the right side we use the even numbers. So that's how we label the electrodes. And then for the numbers, the closer is to the midline, the lower the number. Okay, so there is 3 types of EEG tests that usually been done, which is one outpatient, which we just do it like a normal, we just come for 1 day and then we just went out after we done that. Then inpatient, usually we stay in hospital. Usually this is common when we want to test the ECG for any sleep disorder, so we have to sleep at the hospital. And the ambulatory is we put the device on the patient itself, and then the patient can do whatever they want. Usually to measure the different brain activity during different activity, like maybe the different brain activity when the patient is eating or sleeping or playing. Usually up to 48 hours. And then basically for any patient, because this is pediatric patient, there is a lot of preparation to be done. Usually we advise the parents so to sleep depress the child, so that when doing the EEG, it's easier for the patient to sleep. But not necessarily if the autistic or the delay or sedated. sedated patient usually for patient that are very young in age, or so maybe they will be very difficult for them to sleep, or maybe they will be afraid of the EEG test. And then clean the hair, no any products on the hair, and then if there is medicine, then just give them medicine as you schedule, but and also give them food, but avoid any caffeine or sugar that can affect any brain activity. And then bathroom, which is very important, so that because the EEG test takes a lot of time, about 40 minutes, and then bring things that can make the child comfortable. And then this is the video to show an example of the child taking the EEG test.
EEG, you just get to lay on the bed and relax.
This is where we will record your EEG. We only have the patient and one parent or guardian in the lab at a time. So choose who you would like to have with you and let's get started. And let both you and mom or dad get settled for the EEG. It is important that you lay down on the bed, on your back, through the entire hookup, which may take up to 20 minutes or more. The actual EEG will run for 40 minutes. We want you to be still and relaxed for the whole test. Remember, EEGs require a little patience and cooperation. To start, the tech will measure and mark your head with a washable marker. These spots are where our electrodes will be placed. The tech may ask you to turn your head from side to side so that all the marks go in the correct places. Next, each of those marks needs to be cleaned off using a mild, scratchy soap. We do this so that we can have a nice, clear recording. In other words, to collect just the information we want to collect. After your technologist has finished prepping all of the marks, they will apply the electrodes. To do this, we use a sticky salt-based paste that does two things. First, it is conductive. This means that it helps the electrodes record the signals from your brain. And second, it also makes sure the electrodes stay in place during the recording. This is a simple part of the EEG hookup with just a quick squish of the electrode onto your head and a soft cotton ball covering for some extra protection. But you will still need to lay still on the bed because if you tried to get up at this point, all of the electrodes would fall off. Once everything is on and the recording is started, parents may hold their children in their laps, so long as the electrodes stay intact. With some patients, cooperation for an outpatient hookup is more difficult. Kids under the age of 5 may have this very common reaction to the hookup process. They do not understand what is being asked of them and may become upset and struggle. In these cases, a patient can be held still for the hookup or even swaddled for the electrode measurement and placement if need be.
Okay. So after the
Head, we want to make sure that they're for the entire test. We will wrap your head with a gauze wrap so you don't have to worry about them coming off when you fall asleep. Lastly, the tech will apply 3 electrodes to your shoulder area. These will record your heart and muscle activities throughout the recording. We are now ready to start. During your EEG, it is important that you stay calm, relaxed, and as still as possible. This is important so that the recording is clean and interpretable for the doctor or epileptologist who will read the study. Sometimes your tech may ask you to relax or lay still if you are moving too much to get an accurate recording. During the EEG recording, the tech will have you perform some activities that help us in collecting as much data as possible. These activities are known as activation exercises and consist of a series of flashing lights called photic and a deep breathing exercise. After these activation exercises, it is time for one of the most important parts of your EEG, the sleep portion. To make it as easy as possible for you to sleep, the tech will get you a pillow and a blanket and turn off the lights in the room. We will stay in the room with you the entire time if you need anything. Once the sleep portion of the test is complete, it's time to turn on the lights, wake you up, and end the recording. After the EEG is complete, the tech will get you all cleaned up.
Okay, so basically that's the step for EEG procedure, which is quite simple, but in reality will be very difficult if the patient is much younger and less uncooperative. Okay. There are also a cap for electrodes of EEG, but I think this is for adult because the size is quite big. Okay. And then for EEG itself, what we have to know is the four types of brainwave that the EEG will collect. So from the highest frequency is the beta wave, which is usually we can see in the conscious state or awake, or when we in a very active concentration, or when we are busy. And then for alpha wave, usually we can access alpha wave when the patient is relaxed and calm, and usually when the patient already closing their eyes and just relax on the back. And then usually the alpha wave will not be present if we are very we are thinking of about something or solving something. And then for theta wave, usually in very young adult and less common in adults, but we can have it usually when we are sleepy or drowsy. And then delta wave is also predominantly found in infants and in adults like us, usually when we in deep stages of sleep. That is why we use this delta wave to document any absenteeism. So this is the example of the wave that we can see. Okay, to determine whether this alpha, beta, or theta, which is the highest frequency at beta, and then second alpha, and then theta and delta. Okay. So EEG montage. What is EEG montage? EEG montage is how the EEG is displayed itself. So usually we use two types of EEG to display the EEG, which is bipolar or differential. So there is, I think, last video to further explain which the bipolar and reference montage. Which one? Where is it?
Here the picture on the way of thinking about displayed in different ways, which are all known as montages. The most common type of montage is a bipolar montage. Here I have a picture of the head from the top down. If we display the difference between FP2 and F8 as a single tracing, it would look something like this, and we call this single tracing a channel or derivation. Next, we move posteriorly and look at the difference between F8 and T8 and display this as a different channel. We continue to move posteriorly, and we have a string of recordings from the front of the head to the back that are linked together. This string of recordings is called a chain. In this case, this is the right temporal chain. Several chains can be placed together in a single display, such as this example of an anterior-posterior bipolar montage. This anterior-posterior bipolar montage is laid out as if we are looking at the top of the head of the patient and they are facing to the right. Therefore, we first see the left temporal chain, then the left parasagittal chain, then the midline, then the right parasagittal chain, and then the right temporal chain. At the bottom, we see a single EKG channel as well. Another common type of montage is called a common average reference montage. Here, in a single channel, rather than looking at the difference between two adjacent electrodes, as in a bipolar montage, we look at the difference between an electrode of interest and an average of the signals of the rest of the head. Here we can see the layout of an average reference montage, which is very similar, but again we are comparing each channel to an average of the rest of the head. Some relative strengths and weaknesses of different
So there's difference between EEG montage, which is more common. We use bipolar, which is we reference it with the next electrodes. But for referential montage, we reference it with average electrodes. And then this is the example of normal awake EEG. And then if okay, so for example of I would say not so normal EEG, you can see here you can see on the upper part on the left temporal, we can see there is like, I think this is delta wave to show focal epileptiform discharge, usually on focal epilepsy. Okay. but the other area are normal. So we can say that this is the focal seizure. And then for generalized seizure, we can see a very haywire EEG, usually found in childhood absence epilepsy.
This is not haywire. This is
Why is that,
basically
you know?
rhythmic. You can see the rhythmic 3 spike per second discharges, and if you look at the, I don't know. I got no. I cannot control your cursor there, but you can see the green line, the green vertical line, isn't it? Nampak tak the green vertical line? Is it green or is it blue line?
Which one?
The one yang vertical line yang ada colour. Is it
Ni.
green or is it blue line?
Blue.
No, that's not blue. The
This
small
one,
blue. Yeah, it's that line. Yeah, that line. So the green line to the other green line is 1 second. Alright, 1 second. So kalau tengok dekat spike tu, dekat yang rhythmic spike tu, if you count that spike, there is 3 spike, 3 curve, right? Ada curve, 3 curve in 1 second kan. So we call it 3 hertz per second, which is pathognomonic for childhood absence epilepsy lah. Okay, so this is a rhythmic spike and wave ataupun 3 spike per second punya discharges for childhood absence epilepsy. Okay, it's not really haywire. It looks very rhythmic. It looks very coordinated. It's involved the whole generalized brain. Maknanya left temporal, central, right temporal, right sagittal and so on. Semua ada spike kan. So this is pathognomonic typical childhood 3 spike per second absence epilepsy. Okay. Habis lah. Ya, kan nak tunjuk banyak-banyak lagi. So if you go back to your very early slide, apa dia yang nombor 2 ke nombor 3, I can't remember the slide numbers. Yang awal-awal lagi.
Indication.
Okay, so you mentioned about brain death confirmation, which is part of the list yang kena buat untuk kita diagnose brain death. Normally in the brain death EEG, it just looks suppressed EEG. Mana, you know, in normal EEG yang Zura mentioned before is you look at the alpha wave, beta wave, delta wave. So there's another wave called gamma wave. Gamma wave is much more faster than beta. Sometimes you can have up to hundreds per hertz per second, or wave rhyme per second. So sometimes we call it super gamma, which is up to hundreds. Hyper gamma up to 200 hertz per second. But brain death is basically just flat line, macam asystole lah, flat line. Very burst, very suppressed background of the brain activities. So you and me, so for Zurain, you know, her brain wave probably beta. For the rest of you, probably alpha, because the rest of you is relaxed. You are listening to Zurain, so your brain wave probably alpha. For Zurain, beta, because you know she's a bit anxious. She's probably tengah berdebur nak present the topic. So she probably has better wave. If you hook up the EEG on her, you know, she might have better wave. For those yang ada gamma wave, it's like, you know, if you are in the fight or flight punya situation. So if you fighting, if you probably tengah bergaduh, tengah bertekak dengan orang ke, if you're doing something yang might increase your heart rate, then you might have gamma wave. And so those are if you membawang, probably membawang is quite relaxed. You might have alpha wave, you might have beta wave. Okay. So the other thing is about epilepsy surgery that you mentioned before. epilepsy surgery, normally we don't really depend on the, so there's two types of EEGs. One type is the scalp EEG, meaning you putting the electrodes on the scalp. The second type of EEG, especially for the epilepsy surgery, you put in the intracranial, meaning you open up the scalp and you put electrode directly onto the cerebral, onto your brain tissues, onto the parenchyma. So normally you use that for the pre-assessment untuk epilepsy surgery. Tapi before we go for that procedure, normally you do the CT scan, MRI scan. You might want to do, we call it a PET scan. PET scan is a PET scan of the brain, looking at the cells, the neuron use up of the glucose. So misalnya kalau korang Google PET scan, nampak macam apa, warna merah, warna biru, warna hijau, images. So they're looking at the brain activities, looking at the cells uptake of the glucose. So warna merah means that the brain is very actively consuming the glucose, consuming the glucose lah. So that's normal punya cell. Kalau yang ada lesion ke, ada the center of the seizure, then normally the edges looks a bit macam yellowy greeny color when you do a PET scan. So that probably the lesion where surgeon need to remove that particular brain area lah. So but we don't use the scalp EEG. Normally we use the intracranial EEG for the epilepsy surgery. Most of the EEG that we like to do is the sleep EEG ataupun sleep deprived EEG. So normally you ask the parents to make sure that the child sleep very late at night, then wake up very early in the morning, so that when they come to hospital for the EEG, so at least you can do a part of a week EEG. Then hopefully by the time they probably a bit mamai, a bit sleepy, then they will go to sleep. Because the switching off, from awake to sleep punya phase, so those are the very and susceptible moment for for the epileptiform discharges to happen. So it's very, very important to do the sleep deprived EEG, because normally most of the EEG that we do during the awake time, normally it will be normal. So if that is the case, then you probably need to repeat multiple times awake EEG. And if you don't see the discharges, epilepsy discharges in the awake EEG, and then the patient is still having a seizure, it means that you need to do sleep deprived EEG, because EEG is not diagnostic tool. It's the supporting tools to diagnose epilepsy. So if you see a patient that had a weak EEG and still having a seizure despite on treatment, then you want to do sleep EEG, because sometimes you might miss, maybe the medication is not suitable for the type of epilepsy syndrome that they have. So EEG can be very tricky to do, because not all children complies. The one that you show about the cat too, suddenly not suitable for children because it's quite big, and they normally use the adult size. So that's why we normally do the yang sticky electrode, and then kita bandage normally dia punya kepala dia. So yeah, it is non-invasive. Sometimes you need to give sedation for them to sleep. So you might want to give them chloral hydrates to induce the sleep. Some center use melatonin, which is the hormone that regulate your sleep pattern as well. So sometimes we use melatonin, which is non-sedative, but it's quite effective in children as well. But however, melatonin is not really available in Malaysia. So not all centers have melatonin. You need to import them from outside, from I think from UK or Australia or US. However, you can buy melatonin from Lazada if you want. Okay, if you got a sleeping problem, the thing that you can do is buy melatonin from Lazada. It's a safe medication. It's not toxic it's quite safe medication. Okay, so if you're struggling to sleep because you got exam next week, buy melatonin from Lazada. Okay, any question about EEG? Okay, so right. Next topic, next procedure.
So I will be present the next topic, which is continuous bladder drainage. So I'm sure everyone had already having experience to perform this procedure. So okay, so these are my content. Okay, so this picture showing a two-way Foley catheter. So it has its own function. Okay, so this one is the two-way Foley catheter, and the other one is the three-way Foley catheter. So two-way, which means it has a balloon port and also urine drainage port. And for three-way catheter, it has one other port, which is for irrigation. So this one is the tip and also balloon, same for Foley catheter, two-way and three-way. Okay, so proceed to the indication of CPD. So for indication, first urinary retention. Second, hourly urine output monitoring in critically ill patient. Daily urine output monitoring for fluid management or diagnostic test. And also CBD also used in intra and post-operative monitoring if the patient having undergo prolonged duration of surgery, requiring large volume infusion or diuretics, and also patient having urinary incontinence. And also CBD is used in post-prostate, bladder or gynecologic surgery, and also used in when the patient having hematuria with clots. But hematuria with clot, normally we use three-way Foley catheter because it have the irrigation port. So the next one is if patient having prolonged immobilization, and also if the patient also having neurogenic bladder or spinal cord patient. So if neurogenic bladder, so the clean intermittent catheter is used in this condition. Okay. So for contraindication of CBD, so it have two absolute contraindication and also relative contraindication. So when the patient having urethral injury, which is typically associated with pelvic trauma, so the patient is contraindicated for CBD. And for relative contraindication, the first one is urethral stricture, recent urinary tract surgery, especially in urethra, prostate or bladder, and the presence of an artificial sphincter. So these are the three types of catheter. So the first one is external catheter. The second one is urethral catheter, which consists of indwelling and also intermittent catheter. And the last one is suprapubic catheter. So for external catheter, so this is the picture that I shown to you, external catheter. So this one is the least invasive one for urine drainage. So it's called condom catheter. Okay, the next one is urethral, so indwelling and intermittent. So this picture showing intermittent catheter, and at the right side is the indwelling catheter. So for indwelling catheter, most commonly used in hospital for short-term bladder drainage, normally less than 3 weeks. And for intermittent catheter, the removal of the catheter immediately after bladder decompression. So it is commonly used in those patients who having neurogenic bladder. So and the last one is suprapubic catheter. So this one is the most invasive catheter and require a surgical procedure for placement, and usually by urologists or urogynecologists. So but this method prevents urethral trauma and stricture formation, and it reduce the incidence of catheter associated bacteriuria. Okay, so proceed. So this picture shown this is example of indwelling catheter, intermittent catheter, and also external catheter. So the intermittent self-catheterizations, So the catheter for clean intermittent catheterization are inserted and removed immediately after the bladder is empty. So it has its own method to insert the catheter to the urethra. Okay. So this is the sizing for CBD. Normally in pediatric we use 6 to 10 French scale. Okay, so this you can see there is other type of CBD like caudate, thematic. This is depend on the types of the tips itself. Okay. So how to prepare for catheterization? So a catheter should be used only when absolutely necessary, and the catheterization procedure itself should be done only by trained personnel under sterile conditioning. So first we need to gather all the equipment. So what we need is catheter, 10 cc shrink, sterile water, cotton balls with betadine, lubricant, sterile glove, flashlight or lamp, urine collection bag, anchoring tape, and disposal bag. And then after we have all the equipments, then we should explain the procedure to the patient. And after that, we should provide for privacy and adequate lighting. And the most important thing is positioning. So for female, so she should be positioned in a dorsal recumbent position with the knee flexed and the feet about 2 feet apart. And also for male position is in a supine position. Okay, so this is the way to insert the Foley catheter in male patient. So you can look so this one start with A. So basically you need to sterile yourself and also sterile the part of you want to do catheter. You want to insert the catheter. So cleanse the genital and perineal areas with warm soap and water, and also wash your hands carefully, and then open the sterile catheterization kit using sterile technique, and you need to wear the glove, and then open the sterile drape and place on the patient thighs, and then apply sterile lubricant liberally to the catheter tip. So and then you need to put the antiseptic solution over the cotton ball and place the urine specimen collection container within easy to reach. And then after that, you need to grasp the patient penis between your thumb and also forefinger. You can see this picture. Okay, and then you need to retract the foreskin of an uncircumcised male, and the glove hand that has touched the patient is now contaminated. And then so you need to use the forceps to hold the cotton balls, and so it will maintain the sterility of one hand. So the forceps you use to pick up one cotton ball, and then you should clean the meatus where you want to insert the catheter. Okay, and then you need to hold the penis like this, 90 degree. Okay, and then you should insert, and then you can insert the catheter inside, and you may encounter resistance at the prostatic sphincter. And you need to pause and allow the sphincter to relax and lower the penis and continue to advance the catheter. So when the catheter has passed through the prostatic sphincter into the bladder, so urine will start to flow. So you can gently insert until 1 to 2 inches beyond where the urine is noted. And then after that, you can inflate the balloon using the correct amount of sterile liquid using 10 cc shrink, and gently pull the catheter until inflation balloon is not against the bladder. You pull outward. You pull downward, outward. And then connect the catheter to drainage system. Okay, and then after that, you should anchor the catheter tubing to the lateral abdomen. So you can see this picture. You anchor the catheter tubing to the lateral abdomen with tape without tensions of tubing, and place the drainage bag below the level of the bladder. So, and then evaluate catheter function and amount color, odor, and quality of urine. And you should remove the glove, dispose of equipment appropriately, wash hands, and document. And lastly, you should document size of catheter inserted, amount of water in the balloon, patient response to procedure, and assessment of urine. Okay, so this is for how the way to insert Foley catheter in female patient. So it's more likely like male, but more simple. So the first one, you should place the thumb and forefinger of your non-dominant hand between labia minora and spread and separate outward. So the glove hand that has touched the patient is not contaminated, and then you should clean around the urethra at the meatus using the cotton ball, so to keep it sterile. And then after that, deposit each cotton ball into the disposal bag. So after the last cotton ball is used, deposit the forceps into the bag as well. And then, okay, after that, you can insert the lubricated catheter into the female patient urinary meatus and angle the catheter outward as it is advanced. And if the catheter will not advance, then you should instruct the patient to inhale and exhale slowly. And this may relax the sphincter muscle. So do not force the catheter. And when the urine start to flow, then insert approximately 1 inch further. And then you should connect the drainage bag to the catheter. Okay. Okay. And lastly, same like male patient. Okay. So for the percutaneous suprapubic catheter placement, okay, this is the picture. So it have two types, either direct puncture technique or Seldinger technique. So the percutaneous suprapubic catheter are placed using sterile technique with local anesthesia and sedation if needed. So basically, we need ultrasound to locate the bladder, and then we can direct puncture the bladder to create the and to put the suprapubic catheter. And Seldinger technique also can be used. Okay, so for catheter care, so it have many. So we should care about the meatus care. So we should ensure the meatus clean, and also we need to if leakage occur around an established suprapubic catheter more than 6 weeks after placement, so we need to replace with a new catheter. And then for monitoring for obstruction or preventing backflow, so the catheter and collecting tube should be free from kinking and fixed to the patient's leg. And for changing the catheter, so for indolent catheter, it should not be replaced routinely. So they should not be changed if flow appears adequate. For catheter removal, the simplest strategy for preventing catheter-related urinary tract infection is catheter removal when the indication for insertion is no longer met. Okay, for the complication, so can be divided into general complication and so specific complication. So for general complication, patient can have bacteriuria or UTI, epididymitis, retained balloon fragments, bladder fistula, bladder perforation, also bladder stone formation. So for specific, for condom catheter, it has most and the most complications are minor and self-limited. For urethral catheter, so maybe patient having some discomfort and urethral trauma and also incontinence. For suprapubic catheter, complications are uncommon. So for prevention, avoid of unnecessary catheterization and catheter removal when the catheter is no longer indicated. Okay, that's all for my presentation.
Okay. I really have nothing else to add on the CBD. Because nowadays you don't really do CBD yourself. You just requested your MO, so your junior to do it for you. Yes. So any question about CBDs? Sorry. So for most of the neurological patient yang ada neurogenic bladders, then they will need at least they need intermittent catheters. Means that the parents been trained how to do in and out, meaning just in and then irrigate all the urine, and then take it out. So sometimes neurogenic bladders patient yang macam spinal bifida kan, ataupun yang ada spinal agenesis, then they will need this kind of like intermittent CBD irrigations. So but those are very temporary. So for the continuous CBDs, for those yang backbound, mainly for the PICU patient. So PICU patient being ventilated, you want to monitor their kidney function by measuring their hourly urine output. So you want to make sure that their kidney is not being knocked out due to sepsis, due to medication that you give and so on. So very important to measure the urine output, especially for those yang very, very common things macam so septic patient yang needing ICU care, or DKA patient and come with DKA patient, regardless whether they are adult or pediatrics. If you got DKAs, you want to make sure that the kidneys is still functioning, and you want to make sure that you are measuring in and out, but very strict input output of their fluids, and then you want to make sure that they are passing urine at least 1 ml per kilo per hour. Because otherwise, if the urine is coming down, if they become oliguric, means that their kidneys also knock out as well. In that case, they might develop acute kidney injury and so on. For those yang ada end-stage renal failure, same as well. You want to measure their urine output at least 1 ml per kilo per hour. Okay, any question you want to ask about this topic? If we go to the last one. Tak ada? Tak ada, go for the last one. Siapa buat? Haziq yang last one?
Saya doktor.
Okay. Baik, yes.
Baik, ya.
Right. So Haziq now have a gamma or beta punya wave in their brain because he's a bit anxious at the moment, but that's fine. We'll listen to him.
Can you see my slide? Ke tak boleh? Boleh
Boleh.
Okay. So basically, I will present to you about the ECG. So, a simple introduction. ECG is basically a device to record the electrical activity of the heart. So, this slide show the most basic ECG wave and its presentation. So, all of you probably know about this already. So, basically, these are just several indications that are required to do ECG. So, all of you can read by yourself. So for the time being, no.
Finish, read by yourself.
No, doctor.
It's almost 10 o'clock. Almost 10 o'clock. We need to finish by 10 o'clock.
Okay, doctor.
Okay.
So for the time being, there are no absolute contraindication for ECG. Only that some of the children might get allergic reaction to the adhesive used to attach ECG on the chest. So ECG leads basically can be divided into two, which are limb leads and also chest lead. So there are 4 electrodes for the limb leads and also 6 electrodes for the chest lead. So for the placement of the limb leads, so for the replacement of the limb leads, macam mana nak kata? You just remember the traffic light sequences. Started at the right upper limb with red, followed by yellow. This is supposed to be yellow on the left upper limb, green at the left lower limb, and black at the right lower limb. And for the chest lead, there are specific placement that need to be followed. So for the lead V1 and V2, they are at 4th intercostal space. The V4 at the 5th intercostal space at the mid-clavicular line, and V6 at the 5th intercostal space mid-axillary line. So the V3 is located between V2 and V4, V5 located between V4 and V6. So basically, the placement of both limb lead and chest lead give us the clue about the question of the heart involvement, as you can see in this table. So however, in special case, just like in infant and also small children, whereby the intercostal space is almost not possible because they are small, we just use the nipple line instead of rib space. So the V1 and V2 located at the nipple line just beside the sternum. V4 located below the nipple line at the mid-clavicular line, and V6 at the below nipple line also, same level as V4, but at the mid-axillary line. So V3, same as before, between the V2 and V4, V5 between V4 and V6. So apa kata, the finding that we can see in pediatric patient is that the heart rate of the infant is slightly more as compared to adult with 140 beats per minute during at birth, and this pattern usually peaks until second month of life and then gradually decrease over the year. So the next finding that is unique for the pediatric patient is the ventricular size. So some sources say that in infant, the right ventricle is slightly larger as compared to the left ventricle. Therefore, in ECG, we may see the baby as they get the right ventricular hypertrophy. However, over the time, the left ventricle will be gaining the muscle mass and normalize during the adolescence. So, another normal finding that you may see in pediatric patients is that they might have the shorter P wave, shorter QRS complex due to the less muscle mass, present of T wave, which is apa kata inverted, and also shorter PR and also QT interval. Okay, basically that's all from me. Okay. Sekejap je.
Okay, but really, you've seen a lot of ECG been done, so
Okay.
it's no different. It's no different to adult punya ECGs. It's the same placement, it's same punya position. Just remember that I would normally say to my student before, we call it write your blue bicycle. So right is red, which is your right. The placement of your apa yang electrode on the limb. So right, your is going to be your left lah. So yellow, which is left. Okay, and then your blue bicycle. So one the blue will be on the left side. And then B, remember B is for ball, for which is your black one. Your black punya black electrodes are going to be on your right leg, because you know, for those yang yang power kaki kanan, dia akan capai dengan kaki kanan lah. So your right, your left bicycle. So that's how I remember my placement of my ECG electrode lah. So okay, so not much I want to comment on that. So obviously it's the same ECG during the adult time and also the PICC. Ini cuma the differences, you are dealing with the small chest in children. That's all. But in terms of interpretation, it's the same interpretation of the ECG. It's not a different one. But as a pediatrician, we always want to calculate your QTC intervals. Okay, calculated QTC, not the measured, is the calculated QTC, because if you see an ECG, you want to make sure that you know the RR intervals and also QT intervals, and then use that values to calculate your QTC, because you will depend on the QTC to see whether this child got prolonged QT syndromes. Okay, there's about more than 20 types of prolonged QT syndromes. Unfortunately, it's only one type yang ada prolonged QTC. The rest of them got normal QTC, despite the irony of the name of QTC syndrome. But only few types yang ada really prolonged QTC. So QTC in children, the value is, Haziq? The normal value for QTC is in children. Tak dengar. Bawa tak dengar lah. Tanya soalan bawa tak dengar. Saja.
Sorry doktor, QTC saya tak tahu, cuma QT je saya tahu.
Okay, online lah. Normal QTC for children. What is the normal range for QTC? Tanya Abe lah. Abe dari tadi tak tanya soalan Abe. So Abe now has gamma and also beta punya wave. She's still looking for answers. Don't know whether she will get the answers or not. Or despite the question, her her brain wave probably still alpha or delta. I don't know lah.
Doctor,
Okay, so
350 to
yeah.
460.
Oh, siapa tu?
When
Oh, ini so one. Okay. So what's the answer again?
350 to 460, around that.
Okay, so basically as long as less than 460 millisecond, mana that's normal lah. Kalau above 460, then we call it prolonged QTC lah. Some pediatric cardiologists will accept up to 500 millisecond. So some of the cardiology, but as a general pediatrician, our rule of thumb, kita punya normal QTC will be less than 460 millisecond. Longer than that, we will say we will refer to cardiology for further assessment. So they will decide whether they want to repeat the ECG again, or whether they want to do a scan, or basically making sure that the thing is you want to make sure that they do, we call it exercise induced tolerance. So exercise induced arrhythmia, because when the heart rate reach about 140, 150, 160, then the conduction system will be corrupted, and then that will probably induce collapse and so on, and then at the time they might you will see the arrhythmia. So that's a very important thing to know about QTC. So most of the neuro patient yang datang dengan collapse, multiple collapse and so on, or there is family history of sudden death in the family, or family history of teenage death, then you are thinking about prolonged QT syndrome. Okay, any question about this short ECG taught by Haziq? Dia pun dah tak sabar nak berkorban tu. Tak tahulah boleh berkorban tak dekat UIA. Alright, no question.
I got a question, but it's not
You
about
got a question.
ECG. It's about
Yes.
other topic. For BP measurement in child, I've read a few journals that said it's preferred to right arm, but I don't know why. BP measurement in children, preferably in right arm. Is there any reason why?
I don't know the reason as well. I do not know the reason, because I don't see any difference between right or left. Tak tahulah kenapa. I don't know why. Because in pediatric we don't have the SOP kata kena buat on the right. For me it's right or left, it doesn't matter. Tak tahulah ini apa ni, SOP dari mana ni? PICC protocol ke ataupun mana-mana?
Okay, but journal NCBI said that, so but they don't say the reason why.
Okay. So if you're talking about journal yang dia orang buat macam study, the reason that they use one side to measure the BP ataupun anything lah, meaning that they need to have kita panggil consistency of the measurement, so that kalau dia kata dia nak measure effectiveness of beta blocker in childhood hypertension kan, so they want to make sure that all the measurement of BP, regardless whether the Doppler BP ke minimal BP ke, need to be done on the same scheme, the same standard. So tak adalah one center measure right arm, there is another center measure right leg ke lower limb and so on. So if you're talking about journals probably, if you're talking about RCT ke research and so on, then that's something different. But if you're talking about guidelines, so guidelines then different lah. Kalau kata low limit and so on. For me,
Doktor, start doktor.
Start pula.
Tadi, just now.
Tadi. Sampai ke mana? Where was I?
Dekat right.
So for me, there is no difference right arms compared to the left arm. I don't know. In 10 years in my career pun, I've not been asked to measure only the right arms. Tak tahulah, maybe Nadia kena buka balik jurnal tu. Mana jurnal tu pasal apa? Is it about a study, or is it because of is it about meta analysis of many RCTs ke? So you need to go back and get them more information about that lah. Maybe dia orang ada their own justification untuk buat only right arm. But so far, what I can understand, I don't see any difference between left arm or right arms to do a BP measurement. Okay.
Okay.
Any other question? Okay, so brainwave is very important. Okay, maintain your brainwave on the alpha and beta. And obviously, if you're sleeping, your brainwave is going to be delta or theta. Okay, do not go over to gamma if possible. Just be calm, and keep your brainwave alpha and beta. Okay, so in your exam pun macam itulah. I don't know how they're going to do your exam. Obviously, I'm not involved in your exam, but I heard that they're going to do one modified long case for your exam. So you do theory next week. Make sure you don't really eat too much of lembu and also kambing. But your theory will be. I don't know who's making your PMPs. I think I did your PMPs. I did your PMP question. It's going to be a tough one if you don't read your seminars punya topics, including your year 3 punya seminars. Okay, your modified long case going to be presented, going to be explained by Dr. Taufik or Dr. Said on Tuesday, I think. So that you know what is basically it's kind of like modified long case. So you're still doing your case presentation and so on, and then we probably will bring you to assess your skill of your technique of examination as well. But it doesn't matter. It's the same thing as well. It's just that this time we do modified long case. We don't do the long case and also short case as we did in your year 3. Okay lah. I think it's already late, so have a good time, a good sleep, and get ready for tomorrow. Tak ada question Tak ada question, kita
And last but not least, we want to thank you for everything, for being our mentor as well, and we pray for you, so hope you pray for us also.
Alright, no worry, inshallah everyone will pass your exam, no worry lah. This is your last one before the final pro. So it should be no problem, okay? Should be no problem, inshallah. Okay, all the best for the exams. Take it easy. As I said, keep calm and keep your brainwave alpha and beta. Otherwise, hopefully everyone will go through this block examination, and your exam pro will be in October time. October time. Okay. Right, all the best. I'll see you around. Hopefully, if you got time, and we're going to adjourn the session with Tasdik for someone else. Right, assalamualaikum warahmatullahi wabarakatuh. Thank you very much.
Thank you very much,
Waalaikumsalam. Terima kasih, Doktor.
Thank you.
Thank you, Doctor.
Terima kasih.